So xenobiotics are the foreign or the toxic substance present in our body. It is classified into two ways. Firstly, the exogenous and secondly endogenous. Exogenous being the food, preservatives, drugs, as well as the industrial chemicals like pesticides present. Endogenous example, the most common one being bilirubin. Uh, exo- uh, how is xenobiotics toxic? Xenobiotics are toxic because in presence of cytochrome P50 enzyme, it releases ROS, which is reactive oxygen species, which leads to antibody reaction leading to cell injury or tissue damage, and it can also lead to uh, also mutation of nucleic acid leading to cancer. So we can remove these toxics from the following process. Uh, Xenobiotics can be removed from biotransformation, which was earlier known as detoxification. The name has been changed because detoxification only involved uh, toxic or the neutralized components, whereas biotransformation also include the non-toxic harmful components in our body. The main function of biotransformation is breaking down of xenobiotics into small, simpler, water-soluble substance that can be secreted through urine. Now uh, now I'll let my friend Ratrika to explain the three phases of xenobiotics.
Phases of Xenobiotics reaction. Phase 1. Compound rendered from a more reactive by introducing group that can be conjugated with a conjugating agent. Example glucuronic acids, etc. Phase 2. Produce water-soluble polar compounds excreted through bile or urine. Phase 3. Conjugation of product of phase 2 into a newer compound. Phase 1 reaction. Type oxidation. Enzyme involved is hydroxylase, which is also known as monoxygenase or mixed function oxidase. Characteristics or examples. It requires cytochrome P450. Example, it is converted, toluene is converted into benzyl alcohol. Dehydrogenase alcohol is converted to acetaldehyde via alcohol dehydrogenase, and acetaldehyde is converted to acetate via aldehyde dehydrogenase. Methanol is converted to formaldehyde uh, via toxication. Ethylene glycol is converted to oxalic acid. Reduction. The enzyme involved is reductase, requires cytochrome P450. Examples, nitrobenzene is converted to aniline, picric acid is converted to picramic acid, paranitrophenol is converted to para-aminophenol. Hydrolysis. Enzyme involved is a hydrolase. Hydrolytic cleavage by covalent bond breakage by addition of water. Examples, aspirin is converted to salicylic acid, acetanilide is converted to aniline. Now I'd like to pass the mic to Angela.
Cytochrome P450. Cytochrome P450 enzymes are a large and diverse family of enzymes primarily involved in phase 1 drug metabolism. These enzymes found mainly in livers, endoplasmic reticulum catalyze oxidation reduction and hydrolysis reactions to make lipophilic drugs more water soluble, this thus preparing them for excretion. Key aspects of cytochrome P450 phase 1 metabolism. Oxidation, the most common reaction in phase 1 involving the loss of electron from the drug molecule. Reduction and hydrolysis, while less common than oxidation, this reaction also contribute to making drugs more polar. Location, cytochrome P450 enzymes are predominantly found in the liver, but they are also present in other tissues, including the lungs, kidneys, and intestines. Significance, phase 1 metabolism is crucial for drug activation. Some drugs need to be metabolized into active forms by P450 enzymes. Drug detoxification, most drugs are metabolized to less toxic and more easily excretable forms. Elimination by increasing water solubility. Cytochrome P450 help prepare drugs for excretion in urine or bile.
Next is phase 2 reaction, which is also known as conjugation reaction, in which toxic and foreign compounds combine with the compound produced in our body to make it soluble, less toxic, and polar compounds. There are some conjugating agents like glucochloric acid, which conjugates the compounds like bilirubin, benzenoic acid with the co-substrate like UDPA, glucochloric acid. Then sulfate, which conjugate the steroids endonol compounds with the co-substrate SAM, S-endol methionine. Then glutathione, which conjugates compounds like aldehyde, epioxides with the co-substrate of glutathione. Fourth one is acetic acid, which conjugates compounds like isozide and sulfoamines with the help of acetyl coenzyme. Then methylation, which converts pyrimidine into the methylpyrimidine and metacarfophenol with the help of PAPs. With the help of PAPs, acetylene phosphosulfate. Last one is glutathione, which converts phenyllactine acid, which helps in the treatment of hyperammonia. Next one is phase 3 reaction, which is also known as modification or excretion reaction, in which in this there are 3 steps. Modification: some xenobiotics conjugates formed in the phase 2 can undergo the further modification in phase 3, like example of glutathione, which further converted into metacuropic acid conjugates. Second is transporters. There are some transporter families like ABC, ATP binding casside transporter families, which includes the multi-drug resistance protein family. Then they further go in the excretion process, in which they excrete from the cell membrane while using ATP. This transport mechanism is crucial for the removing the water soluble and modified compounds of the cellular environment.
Cool. See, you must participate. Any question? No question. Fine, I have one question. Go to the first slide. Here, you answer. Rule number 2, right? What is the difference between biotransformation and detoxification? Why this name has been changed? Biotransformation.
Biotransformation is a process where the toxic substance is converted into the less toxic, more toxic,
Mic-টা কাছে নাও, বুঝছো?
less toxic, more toxic, or non-toxic compound. Or bioactivation, this is the process where the toxic compound is converted into a more toxic compound.
Where?
Detoxic liver.
Detoxification.
Redu-
No, why this new term was necessary?
Sorry, sir.
আগে এটাকে বলতো ডিটক্সিফিকেশন, এখন বলা হয় বায়োট্রান্সফরমেশন। এই নতুন টার্মটার প্রয়োজন হলো কেন? বলো, বলছিলে, ঠিকই বলছিলে, বলো।
স্যার নামটা চেঞ্জ কেন হয়েছে?
নামটা চেঞ্জ কেন হলো?
Detoxification process where the toxic substance is converted into the less toxic or more polar compound.
আরে মাইকটা বই কাছে নিতে অসুবিধা হচ্ছে।
না স্যার।
মাইকটা বই কাছে নেই, এরকম ভাবে ধর।
Sir, detoxification where the detoxification is the process where the toxic compound is converted into less toxic or water soluble compound.
হ্যাঁ,
For
ঠিক আছে, তারপরে হ্যাঁ,
expiation.
কিন্তু বায়োট্রান্সফরমেশনটা তফাৎ কোথায়? What is the difference of biotransformation? Anyone? What is the necessity for coining new term called biotransformation? See, I give one example like methanol. Okay, when methanol is oxidized, it forms formic acid. When ethanol is oxidized, it forms acetic acid. Acetic acid is not non-toxic, but formic acid is toxic. So both are taking place in the liver. So by the process, if we put this oxidation under detoxification, then formic acid is more harmful than formaldehyde. Hence the new name called biotransformation was necessary. Sometimes it may become more toxic due to some biological reaction. Okay? Anyway, presentation was good. Okay, next.
Good afternoon to my teachers and all my friends present here. Today our team is going to present a PowerPoint presentation on the topic inhibition of translation. So what is translation? Translation is the process by which cells make proteins by decoding information present in mRNA. It takes place in ribosomes present in cytoplasm. It involves transfer RNA or tRNA that acts as interpreter of mRNA. Why do we need translation? Translation is important for the formation of proteins that are important for cell growth, maintenance, repair, and proper functioning. If there is no translation, then these proteins will not be formed and the cells will not be able to survive. What do we mean by inhibition of translation? Inhibition of translation simply means either stoppage or slowing down of protein synthesis. This can be achieved by the following three ways: breakdown of mRNA, blocking of ribosomes, or interference with the starting or continuation of the protein synthesis process. Now, mechanism of translation. The translation involves three steps: initiation, elongation, and termination. Initiation. The small part of the ribosome attaches to the mRNA. It reads the mRNA. The first tRNA brings the amino acid methionine, which is also the start codon. The large part of the ribosome also joins in. Thus, the mechanism of protein synthesis is ready. Now, elongation. As the ribosome keeps on reading the mRNA, the tRNA keeps on bringing the right amino acid one after the other. And the large ribosome binds this amino acid. Each of these amino acid binds to the polypeptide chain. So, the protein chain is being formed. Now, termination. When the ribosome reaches a stop codon, which can be either of these three codons, UAA, UAG, or UGA, then the polypeptide chain is released and the translation process stops. Now, types of inhibitors of translation. Inhibitors are also called antibiotics, and they work on bacteria but are non-toxic to humans because humans have 80S ribosomes while bacteria have 70S ribosomes. There are two types of inhibitors of translation: inhibitors of eukaryotic translation and inhibitors of prokaryotic translation. Inhibitors of prokaryotic translation are of two types: reversible inhibitors, irreversible inhibitors. Now I would request my team member Anna Tasnim to explain the rest of the slides.
Thank you, Amrita. Let's take over the rest part of the topic. The irreversible inhibitors of the bacteria are mainly of bacteriostatic. The tetracycline bind to the 30S subunit of the bacterial ribosome, so inhibit the attachment of the amino acyl tRNA to the A side of the ribosome. The chloramphenicol inhibits the peptidal transferase activity of the bacterial chromosomes. And rest, the erythromycin and clindamycin prevent the translocation process. Let's understand the irreversible inhibitors of the bacteria. They are basically of the bactericidal type. Streptomycin and Streptomycin and all other aminoglycoside antibiotics bind to the 30th subunit of the bacterial ribosomes. They cause the misreading of the mRNA and at huge concentrations. They completely inhibit the initiation complex formation and totally inhibit protein synthesis. Let's come to the topic, that is the inhibitor of the protein synthesis in eukaryotes. We have the puromycin. The puromycin is structurally similar to the tyrosine tRNA and gets attached to the A site of the ribosome. So the incomplete peptide is released. It acts both in bacterial and mammalian cells. Then cyclohexamide inhibits the peptidal transferase in the 60S subunit. It acts only on the eukaryotic cells. Then the diphtheria toxin liberated by the bacteria, Corynebacterium diphtheria, causes the inactivation of the EF2 by the attachment of ADP to EF2 and the consequent inhibition of the protein biosynthesis in mammalian systems. Then come to the application of the inhibitors of the translation. At first, we have antibiotics like tetracyclines and aminoglycosides inhibit bacterial protein synthesis. We have cancer treatment as an application. Translation inhibitors like omacitaxin target rapidly dividing cancer cells. We have the antiviral therapy as well as we have the antibacterial therapy. Some translation inhibitors target viral protein synthesis, and the translation inhibitors are used to treat bacterial infections, as well as we have research tools. Translation inhibitors are used to study protein function and cellular process. In conclusion, the translation inhibition is a crucial mechanism that can be leveraged to its effective therapeutics and research tools. Understanding the process of the translation and its inhibition can provide valuable insights and cellular function and in the disease treatment. Translation inhibitors have diverse application in medicine from antibiotics to cancer treatments. By exploring these concepts, we can unlock new possibilities from improving human health. Thank you.
Any question?
Normally, first and foremost, I must congratulate both of you, particularly the first speaker, for speaking very nicely. I'm quite impressed. I've been delivered the lecture just like a teacher and not like a student. That much I must appreciate at the very outset. I think all of you must appreciate that thing. At this level, it was really an outstanding speech, I would say, as the first speaker. Go back. Where from you got the slide? I mean, what is the source of this information? What is the source of this information? Which book?
Sir, Vasudevan.
Just bring it down. Go ahead. Inhibitors are also called antibiotics. The definition of antibiotic is that it's a chemical substance produced by one organism which inhibits the growth of another organism. So therefore, all the things did not necessarily be antibiotic while we are discussing. This part must be very much clear. Fortunately, the chemicals what we use are all antibiotics. Inhibitor, reversible, irreversible, whatever you are telling, in connection with bacteriostatic, I made it very clear in my class that bacteriostatic drugs are the drugs which inhibits the replication of the bacteria so that the bacteria cannot grow and the body's immune system take care of all those organisms. So basically, when the infection is basically mild, then bacteriostatic drugs are used, and our body systems are triggered to function properly, so that during the next infection, your immune system improve response to that particular bacteria or offending agent nicely. Second, bactericidal drugs are given when the infection is severe and the body's immune mechanism cannot control the infection simply by bacteriostatic drug. So at that time, bactericidal drugs are given to kill the bacteria completely, so that the immune system will not be required to function, and rest of the replication, rest of the bacteria, whatever is present, if at all, that bacteria, our immune system can take care of it. Normally, when the infection is severe, usually even after the bacterial infections are negative, usually 1 or extra 2 more days are given to continue the drug, only to ensure that whatever bacteria or virus which is the infective agent which is causing the disease can be totally eliminated from the body, so that there will be no chance of recurrence of infection. This part must be clear. And regarding research field, any chemical can also be used. Competitive inhibition, the moment you say, that means similar structure has to be given, which will reverse the action. That is the difference between the reversible and irreversible. Okay? That's it. But you, second best speaker, you just tell all these things, a little bit towards the audience, not by looking at the things. And the second rule of preparation of slides, I would say for the next slide, don't write complete sentences. Write partial sentences, and the rest of the things you look at the audience and tell. That will be a better way of speaking, the way the half speaker has been expressed or delivered in our lecture. That is the ideal way. Okay. Thank you very much for both of you.
Good afternoon, one and all present here, respected professors and all my dear batch. Shasmani, along with Anjali Kumari on stage, are here to present to you an overview of carbohydrate metabolism and its results. So starting with carbohydrate metabolism, carbohydrates can be classified into 3 types based on the sugars they contain, namely monosaccharides, disaccharides and polysaccharides. Beginning with the disorders of monosaccharides, we have 3 classical examples, namely galactosemia, essential fructosuria and fructose intolerance.
So in disorders of monosaccharides, we have 3 disorders. First is galactosemia, essential fructosuria and hereditary fructose intolerance. Starting with galactosemia, it is a autosomal recessive disorder where the body is unable to convert galactose to glucose. It is of 3 types, mainly 3 types. Type 1 is classical galactosemia, where the defective enzyme is galactose 1 phosphate uridyl transferase. In this, the major clinical features are hypoglycemia, cataract and unconjugated jaundice. Cataract occurs because the galactose is reduced to dulcitol and it gets accumulated in eye lens, causing congenital cataract. The second type is due to the deficiency of galactokinase. In this, the main clinical feature is congenital cataract. Type 3 is due to the deficiency of galactose epimerase. It is usually asymptomatic. The second disorder is essential fructosuria. It is a genetic disorder of fructose metabolism. The deficient enzyme is fructokinase. The main clinical feature is fructose gets released in urine. This condition is usually harmless. The third disorder is hereditary fructose intolerance. In this disease, small intestine is unable to absorb fructose. The main clinical features are abdominal pain, diarrhea, vomiting and hypoglycemia. The treatment may include eating less fructose.
Continuing with the disorders of disaccharides, we have one classical example of the lactose intolerance. So lactose intolerance is an rarely occurring disease which mainly occurs due to deficiency of lactase enzyme. The typical symptoms are abdominal cramps, diarrhea, and flatulence. The two factors contribute to lactose intolerance are lactose malabsorption and gut sensitivity. It's the inability to break down and absorb lactose in a small intestine that leads to lactose later enter the large intestine and triggering the symptoms. Lactose intolerance can also be classified into four subtypes, namely the primary lactose intolerance, secondary lactose intolerance, congenital lactose intolerance, and the developmental lactose intolerance. One summary about all of them, the primary lactose intolerance is the most common type, which develops as people's age and lactose production naturally decreases here. It is more prevalent in certain ethnic groups. The secondary lactose intolerance occurs when the small intestine is damaged or diseased, leading to reduced lactose production. The congenital lactose intolerance is a rare and inherited condition where a person is born with the ability to produce lactase. It requires immediate medical attention. And the developmental lactose intolerance is seen usually in premature infants where the small intestine are not fully developed, leading to temporary lactose intolerance. Next, continuing to the polysaccharide disorders. So next, moving on to the disorders of polysaccharides, we have one typical example, that is the glycogen storage disorder. It occurs when the body isn't able to produce, the body is able to produce the glycogen, but it cannot build up or break down or use the glycogen in appropriate way. The glycogen storage disorders are of mainly 6 types, namely the type 1, also known as von Willebrand's disease, type 2, known as the Pompey's disease, type 3, known as the Cory's disease, type 4, known as the Anderson's disease, type 5, known as the McArdle's disease, and type 6, known as the Hirsch's disease. Next, we have a table summarizing all the disease mentioned in the previous slide. It says type 1, von Willebrand's disease, which occurs due to deficiency of the enzyme known as glucose 6-phosphate. The clinical features seen here are fasting hypoglycemia, hyperlipidemia, hyperuricemia, lactic acidosis, and hepatomegaly. Type 2, also known as the Pompey's disease, which occurs due to the deficiency of lysosomal acid mutase enzyme. The clinical features are hypotonia, floppy infant, poor feeding, breathing problems, glycogen accumulation in heart, liver, and tongue. The type 3, known as the Cory's disease, mainly occurs due to deficiency of the enzyme known as the debranching enzyme. The clinical features are fasting hypoglycemia, hepatomegaly, delayed growth, myopathy, dextrin accumulation. Type 4, the Anderson's disease, occurs due to deficiency of branching enzyme. Clinical features seen are splenohepatomegaly, cirrhosis of liver, and failure to thrive. The type 5 is McArdle's disease, which occurs due to deficiency of muscle phosphorylase. Clinical features are exercise intolerance, myoglobinuria, and accumulation of glycogen in muscles and liver, which causes fatigue. The type 6 is Hirsch's disease, occurs due to deficiency of the liver phosphorylase enzyme. The clinical features seen are hepatomegaly and fasting hypoglycemia.
So the other disease related to carbohydrate metabolism disorders are, the first is diabetes mellitus, both type 1 and type 2. The second is diabetic ketoacidosis. So moving with diabetes mellitus type 1, it is usually present in small children. It is an autoimmune condition where the body immune system destroyed its own pancreatic cells. The main clinical features are polyuria, polyphagia, and polydipsia. The diagnostic features are the serum blood glucose is more than 126 mg per dl. Random blood glucose is more than 200 mg per dl, and glycated hemoglobin is more than 6.5%. Diabetes mellitus type 2 is more common diabetes. which is usually present in adult. It is a condition in which the body becomes resistant to insulin. The most common symptoms are weight, weight gain, frequent urination, increased thirst and fatigue. Uh, if the diabetes stays for a long time, there may be chronic symptoms such as cataract due to the accumulation of sorbitol. And there are same features of both type 1 and type 2, which is polyuria, polydipsia, and polyphagia. Moving to diabetic ketoacidosis.
And lastly, we have diabetic ketoacidosis, which is an acute complication of diabetes type 1, diabetes mellitus type 1. It occurs when the body starts breaking down fat at a very high rate due to insulin deficiency. Some of the causes related to it are diabetic ketoacidosis develop when the body doesn't have enough insulin to allow body sugar to be used as energy. Therefore, the uptake of glucose by cells are decreased. Thus, liver break down fat for energy, producing large amount of ketone bodies. Then the next cause is And the next cause are hyperkalemia, which occurs because ketone bodies are generally acidic in nature and bicarbonates are used for buffering them. Thus, the pH is reduced, leading to metabolic acidosis. And lastly, when insulin is lacking, potassium moves out of the cell, exchanging an H plus ion, thus raising the potassium level in plasma, causing hyperkalemia. Then the lab diagnosis we have are very high plasma glucose, that is hyperglycemia, Benedict's test positive, that it shows that reducing sugar is present, Rothera's test positive, that is ketone bodies are present, metabolic acidosis is present and pH is less than 7.35, hyperkalemia is present, that is the level of potassium level in plasma is raised. Clinical manifestation are too small breathing, deep and rapid breathing, confusion, irritability, low BP, excessive thirst, blurred vision, vomiting, abdominal pain, excessive urination and fruity smelling breath. And the treatments are insulin therapy, IV liquids and regular monitoring of blood sugar, potassium level and blood pressure. These are the symptoms of the diabetic ketoacidosis, and thank you for your patience and cooperation.
Anyways, good presentation. But thing is, you should look to the audience. You should face the audience while speaking, not the board. Number one. Okay. Any questions, sir?
You try to interact. Otherwise, this is the basic purpose that you, don't have any fear psychosis of delivering a lecture in future anywhere from a podium. And you must ask some questions, maybe pre-informed, only to have an interaction, nothing more than that. We don't want that you will harass him on the stage. No, that is not the purpose. The purpose is that you try to speak. See, देखा तो ये चार्ट देखा तो ग्लास डिजिटल चार्ट देखा चार्ट देखा पॉइंट देखा. What is the mistake? There is one single mistake is there.
It must be glucose 6-phosphatase.
This is number one. Number two, when you are indicating any enzyme, the first letter can be capital and next letters must not be capital at all. Like glucose 6-phosphatase was there, but phosphatase, you see the word letter, it is a small letter. Similarly, lysosomal acid maltase, A must be in the small letter, maltase must be in the small letter. That is number one. Second, can anyone explain why fasting hypoglycemia occurs in this hall? Can you answer why fasting hypoglycemia? Why fasting
Sir,
hypoglycemia
because
occurs?
glucose 6-phosphatase enzyme is deficient, so glucose 6-phosphate cannot be converted to glucose, so it cannot be utilized by the cells, so hypoglycemia is there.
And then why lactic acidosis? And then why hyperuricemia?
Hyperuricemia occurs because the glucose 6-phosphatase enzyme is deficient, so glucose 6-phosphatase accumulate, and then it goes to HMP shunt, which then it converts to ribose sugar, then फिर प्यूरिन पायरिन को तो डिग्रेडेशन से यूरिक एसिड का लेवल रेज होता है, तो हाइपरयूरिसेमिया.
Actually, the actual clarification is that when there will be hypoglycemia, when the overnight fasting is there will be definitely hypoglycemia. Okay, liver will not be able to produce the fasting blood glucose level is maintained by the glycogenolysis and neoglucogenesis to maintain blood glucose level. When there will not be any proper glycogenolysis because of the blockage of glucose 6-phosphatase, glucose 6-phosphate will not be able to come out from the cell. Glucose 6-phosphate being an active metabolite will be utilized by the cell as much as possible, producing energy. When the energy will be, charge of the cell will be very high, all the synthetic mechanism will be accelerated. When that will be saturated, again the glucose will follow a pathway of anaerobic glycolysis and the pyruvic acid will be converted to lactic acid. This lactic acid will come out of the cell, it will enter into the circulation and it will try to pass from the kidney at the distal convoluted tubule by competing with the hydrogen concentration, and lactic acid will be excreted in preference to the uric acid, and that's why the uric acid will be retained and the blood glucose level will be, further hypoglycemia will occur and this cycle will continue. Therefore, only when somebody is not taking adequate amount of food, then only this type of problem will occur, otherwise not. Second part is hyperuricemia, the mechanism which Dr. Sandeep also told, that is the mechanism because uric acid also competes with the same pathway at the distal renal tubule, convoluted tubule for excretion. So that pathway will also be, there will be again competition with the hydrogen ion because of the lactic acidosis, because the body doesn't want to have an acidotic condition. And second part was blood glucose. I told you repeatedly during diabetes class that blood sugar is a loosely used term. Never use sugar, always use glucose. Whether you use blood glucose or whether you use plasma glucose or serum glucose. But please try to avoid blood glucose because our seniors used to say, and there cannot be a vertical transmission. Even at your stage that you will also continue to say blood glucose sugar. No, you please say blood glucose and plasma glucose. That much I expect from the next generation. Okay, thank you. Thank you. Never say blood sugar. Blood sugar is a common term. It's a loosely used term. They used to say in the past, and we have inherited that particular term from our seniors. And you must not do that thing from your level. Okay. Thank you. Thank you very much.
Thank you, sir.
Anyway, end of today's session. So, see, there are so many things. When you are writing, when you are presenting, you are preparing a slide, you must avoid taking photographs from books. If not, otherwise, it is inevitable. You must be practicing how to write, number one. Number two, when you are writing, preparing the slides, make sure the diseases names, enzymes names are actual, not what you think it should be. There are plenty of spelling mistakes in these. Those who have taken the pain to write, prepare their own, they have made spelling mistake. And those who have copied, it is not desired. So prepare your own, number one. Number two, prepare it so that you need not to look at the slide while delivering the lecture. Number three, when you deliver the lecture, learn how to give proper pause while speaking. Like, what is your name? No, it's not like that. My name is, give a pause, then you say something. Correct? When you are presenting your name on the dash, I doubt anybody understood. Is there anybody who understood what they're speaking, what about the names? No. It is not just vomiting what you are marked up in the backstage. Do not vomit. Speak. Present. Do not vomit. Okay? So next day, whoever is delivering, try to keep this in your mind when you are delivering the speech. Correct? It is the way how you present, it matters. How you present it matters more than what you present. Definitely what you are writing, we will look that also, whether it is correct or incorrect. But how you present. Like this group, they presented very well. Ananya and they presented very well. Anyway, your name? Amrita. Anyway, Amrita has a manufactural defect. She cannot smile. So we all know that. Correct? If you don't look at that, otherwise she is good. She is perfect. Yeah. Ananya delivered a very nice speech. Very good.
One point I forgot to tell you, those who have presented the last part, that is diabetes complication. Well, diabetic ketoacidosis is common. Can you hear? Can you hear properly? So diabetic ketoacidosis is common. There is no doubt about it. There is one more entity, that is hyperosmotic hyperosmolar syndrome, HSS. This is in that condition. There is almost a very high level of blood or plasma glucose level, but without any ketone bodies. That is called HSS, hyperosmotic syndrome, HSS syndrome. This occurs usually in the elderly patients who are not cared for, who don't bother. I mean, those whose brains are not functioning properly, they are uncared for, they don't take medicine, they are chronically blood glucose level elevated. They are also having maybe 600, 700, 800 blood glucose level or plasma glucose level, but they don't exhibit the ketone bodies in their urine. So their management is a little bit different than what the diabetic ketoacidosis is. The diabetic ketoacidosis is common with type 1 diabetes. Again, with type 2, primary OHA failure, those who are again put on insulin to control their diabetes. These are the conditions. These you must remember. Particularly, don't forget about HSS syndrome in elderly patients, because you have to handle some aged patient. Life expectancy has increased. So you will be getting older patients with diabetic patients with HSS, not classical DKA cases, what had been discussed. Okay, thank you.